All right, it's 7 o'clock. So I'm just going to welcome everybody to this evening's session. Thank you to those of you who's joined so promptly. We really do appreciate that. We have expected over 100 people who've registered this evening, so we might wait just a few moments in case some more people join us. I'm delighted to be introducing this evening's event. My name is Lisa Drake, and I'm a member of the expert advisory panel that were available to the research team on the Remote by Default research project. So this evening, you're going to hear from some of the researchers and their key findings of the project. But before I hand over to tonight's presenters, I'd just like to run through a little bit of housekeeping with you, if that's okay. This is primarily an information sharing session, and we have a lot of detail to give you in a short space of time. So we've disabled the chat for this evening, but we've made available to you the question and answer panel. So you should see on the top of your screen a little button that says Q&A. I can see there's a red dot there, so somebody's already asked a question. That's great. If you can pop any questions you have in there, Dr Rebecca Payne will be checking and keeping an eye on those questions, and we'll run through them with you at the end of the session. You can choose to post anonymously if you like, or you can pop your own name in if you want. Now, this session is going to be recorded and it will be hosted on the research website as a YouTube video. So for that reason, please can I ask that you do not post anything personal in your questions. If you can, the research team will answer the questions as they go along, or they may summarise a few questions into one if several of you have asked the same question. I think it's fair to say that we're all patients and users of the NHS services, so we all have a vested interest in getting this right, if not for ourselves, but for our families, neighbours and communities. So I'm going to hand over now to Professor Trisha Greenhalgh to give the introduction to the evening as the project lead for the research.
Thank you very much, Lisa, and thanks to the National Institute for Health Research for funding this. Thanks to you, Lisa, and the rest of our advisory group, and thanks to lots and lots of researchers from different places who are part of this team. So what's this all about? If you remember back in that very early stage of the pandemic, where everything went remote, didn't it? You couldn't walk into your GP surgery, you had to phone up or you had to get online. And in about June 2020, Matt Hancock, who was the Secretary of State for Health at the time, got up and said, isn't this a great idea? Let's make the whole of healthcare remote by default. And it went down like a lead balloon. Nobody wanted to carry on at that point. You know, we'd all just come out of lockdown. We were finally able to sort of, you know, do normal things again. The kids were back in school. And the last thing we wanted to do was to carry on with an exclusively remote service. And actually, over the next few months, the policy pendulum swung in the other direction. And people were saying, oh, no, you have to have a choice and patients need to be face-to-face by default. And remote is only, you know, at extreme. Well, we managed to catch the middle of that pendulum swing with this grant, which was about remote by default 2. So remote by default 1 was when we had to be remote. And this was saying, well, what's happened after the acute phase of the pandemic? What kind of services should be remote and what kind of services need to be face-to-face? And within that big box of remote, there's a lot of high-tech stuff. There's video consultations. There are e-consultations where you get onto your computer and type in a few questions and then someone will get back to you, not in real time, but maybe a few hours later. But there's also the old-fashioned telephone. And actually, the vast majority of consultations that are remote happen by telephone. So on the one hand, it's very futuristic. On the other hand, we've gone back to the phone. So what did we do? We're qualitative researchers. We went to 12 general practices up and down the country, from Scotland through to remote Wales, through to the centre of London, down in the West Country. And we chose these 12 practices to give us a real spread of the kind of general practice that exists in this country. So some of the practices were very tiny. One had 2,000 patients. Some were huge. It had 31,000. Some of them were one of them was in a rather affluent area. More of them were in deprived areas. We call that oversampling because we were particularly interested in disadvantaged areas. And then what we did with these practices, the other thing is some of them were very advanced technically, they were sort of state of the art with all the new tech, and some of them were very, very basic, with a lot of them somewhere in the middle. So we visited those practices repeatedly for a total of 28 months, so nearly 2.5 years, went back and we hung out and made notes and talked to people, talked to the patients and the staff, talked to the receptionists, talked to the clinicians, the trainees, etc., etc. Made a lot of notes, did a lot of recordings, and then we came back, pulled it all together, and quite early on, there were a number of high-level themes that were coming out. One of them was inequalities. Some patients found it really easy to access care. Some patients, perhaps the ones who weren't very techie, found it much, much more difficult. There was a theme around whether this new tech was creating inefficiency, even though it had been introduced to make care more efficient, but tech can be quite stressful, as I'm sure you know. There were themes around training and workforce. You're going to hear about those. So I'm just introducing the overall study, and I think I'm going to stop there actually, because I don't want to steal anyone else's thunder. And then towards the end, I think I come back again, and if there's anything I've forgotten to tell you or other people haven't filled in, then I'll fill that in some more. But I think I'm handing back to you, Lisa, the chair. Am I, or am I going straight across to Gemma?
No, I think straight across to Gemma now. Thanks.
Straight across to Gemma. I'm going to lob the ball to you, Gemma.
Thanks very much, Trish, and thanks everyone for listening in. My name's Gemma Hughes and I'm one of the researchers working on the team. I now work at the University of Leicester, but I was previously working at the University of Oxford. And I'm going to talk to you about a bit of research that I did as part of this study with colleagues on this idea of care navigation and digital care navigation. So what I'm going to cover very briefly in the next 5 minutes is say a little bit about what care navigation is, what we found and what this might mean for patients. If you could move the slide on, please. So what is care navigation and what is digital care navigation? Really, care navigation refers to any of the work that might be done to advise or support people as they try to find their way around the healthcare system. So digital care navigation includes any help needed to access healthcare using any digital technology. What we actually found was that digital care navigation and care navigation are not really separate activities, because if you're supporting someone to access healthcare, it invariably involves some form of digital communication, whether that's filling in an e-consult form or even just looking up clinic times on a web page or finding the phone number to call. But the idea for this particular part of the study came from our concerns about digital inequalities, the fact that some people find it harder to access primary care through digital technology than other people. And this came up in our research during the pandemic as well, where we observed people being supported to access primary care in situations that weren't necessarily set up to deal with their healthcare. So, for example, one of our colleagues who worked down in Plymouth, Sarah, observed homelessness workers supporting people to get remote GP appointments during the pandemic by helping them with their devices, with data, and finding quiet places to call from. So we wanted to find out more about the kind of work that was needed and how people in different settings were offered support with digital care navigation. So what else might we call care navigation and who does care navigation? If we could move on to the next slide, please. This slide shows a whole load of words that we found were associated with care navigation. So lots of different words like care coordination or social prescribing are used to describe similar kinds of work that connect people with health services. We found that not many people involved in this kind of work will actually be called a care navigator. It's not often a specific job title. More usually it's a skill or a function of lots of other jobs. Some of these jobs are within healthcare. So, for example, a GP receptionist or a practice nurse might help navigate people around. But they also exist in jobs outside of healthcare. So the example I gave of someone working in a homeless hostel. What we didn't look at for this bit of the study was any of the work that family or friends did to support patients. Instead, we were interested in people who were working either as volunteers, but usually in paid work in some shape or form to support people to access primary care. So as Trish said, we interviewed people, we observed what they were doing, we asked them about their work. So what did we find? If you could move on to the next slide, please. We divided the process of digital care navigation, and I'm going to run those three words together, into three areas, quite simply: navigation into primary care, navigation within primary care, and then navigation onwards from primary care. And actually, the bit that was most problematic or difficult was that navigation in. That was where people needed most support. So we started to map out all of the steps that were needed to help people get into primary care and the interactions that were needed at each step, and how those interactions involved both people and technologies. I'm going to show you an example of a map that we made of somebody staying in a homeless hostel getting to see a GP. Now, this looks a bit complicated. On the face of it, this process should be quite simple, because actually what the GP did was they ran a clinic, a weekly clinic in the hostel. So from the primary care's perspective, it seemed quite simple. But when we looked at what actually happened, we found that there were lots and lots of opportunities for this process to break down. There were lots of nodes in the network. There were lots of connections needed, lots of interactions needed, both with and without technology. And that meant it became particularly complicated and difficult for people to get to primary care, and lots of opportunities for them not to get to primary care. In particular, it was difficult for people to wait for callbacks from different services. In the homeless setting, people are not necessarily in a stable place, and they find it hard to wait around. They don't necessarily have their own device with them. They have to liaise with the hostel worker, for example. So this was just one of the maps that we drew from different interactions and different routes that people took into primary care. So what are the implications of this? What does this mean, and why does this matter? If we could just move on, I think this is my last slide. So these are some of the important points that we came up with. Really, for some people, the work to support them before they access primary care is really, really important. It can be really complex work, and that work isn't always apparent to the primary care providers. Navigation within general practice, including all the kind of digital tools, as well as the different link workers and jobs and functions that exist within general practice that help people get to the right clinical member of staff, or indeed help them access other services, whether they're health services or other related services. Once you're in there, that's quite well set up, and quite not necessarily easy, but there's work going on there that people can follow the system through. If we think back to the map or the network of things that needed to happen in that homeless hostel example I gave you, one of the things that was really striking was the importance of face-to-face support to provide that digital care navigation. Synchronous support is really key. Waiting around for a callback was often the point at which that network broke down for individuals. So that's a really quick summary of the work that we did that specifically looked at digital care navigation. And I'm going to stop there, and very happy to take any questions either through the chat or at the end of the presentations. Thanks very much for listening.
And I think that's my cue to start. So I'm going to now talk to you really briefly about how these new technologies can complicate access to general practice for patients more broadly, and why that's important when staff are triaging people. So to access general practice, patients must know where the front door is and how to access it, which now often means calling the practice or using the internet to access the practice webpage and fill out an online request form, which will often have lots of different steps and requires lots of different types of information. Patients must know how to talk about their symptoms, and that means being in touch with what's normal or not in your body, and being able to describe those symptoms verbally or by writing them out on your keyboard, and knowing what's important information for the staff so that they'll be able to rank your neediness in comparison with other patients who might be accessing care. Patients also need to be confident to self-advocate, sometimes more than once, on their pathway to care, in case practices might have misinterpreted how soon they need to be seen, or if they've been allocated to a mode of consulting or a professional that that patient might not agree with. For example, being allocated to a telephone consultation when they really just want to see someone face-to-face. Now, this is tricky because the paths to digital access have inbuilt assumptions about what patients can do, what their needs are, and their skills, and that limits how those technologies can be used and who can use them. So, for example, if you can't find where the online form is on a practice website, you can't fill it in, or if you find the repetitive questions frustrating, you might actually just give up. Or if you select certain answers like chest pains, then you might end up being caught in a safety trap, being told to go to A&E when you only wanted to see a GP. There are also some patients who are very empowered to use digital access platforms and find it really intuitive. And for these patients, their threshold for access might be lower, so they might be using up system capacity for comparatively less important things. Or they might know shortcuts to game the system using specific symptoms or phrases to get access faster than they might faster care than they might clinically need it if they had been triaged with more accurate information. If we can go into the next slide, please. Thank you. Now, this matters because staff use the information provided digitally by patients to help them determine their eligibility for care and triage them to the right healthcare professional. An accurate assessment relies on the accuracy of this digital representation. So inaccurate information means that people might be given the wrong kind of care or allocated the wrong place in the queue. Sometimes staff can fill in these gaps using their knowledge of specific patients to create more accurate representations, but higher turnover rates and higher staff workloads means that this is getting less likely. Now, all of this is really important because we saw that patients' experiences at the digital front door of general practice influence their ongoing engagement with the healthcare system. So being deemed not eligible for care when they sought it on one occasion could shape their future self-assessment and help-seeking behaviour. Now, that's all that I have time for in this section, but if you have any questions about this, then please do write them in the chat. I'd love to answer them at the panel section. Thank you.
So I think it's now me. So I'm Nadia, and I'm a carer, and I'm also a researcher on the team. And you might have seen some headlines in the news when the study came out that made it seem like talking to a GP over the phone was actually dangerous. But I don't think those journalists read our study properly, because what it actually says is that we hardly found any examples which made it unsafe for patients to talk to GPs over the phone. Can I have the next slide? So Trisha's talked about how we followed these 12 GP practices for over 2 years. And in that time, we didn't see anything in those practices that affected the safety of patients. No major safety events. And we really had to look quite hard and look nationally to find safety events that we could learn from. And I'll come back to those. If we go to the next slide, I tried to set out here from the study why it is. What did we find in the 12 GP practices? You know, what did we find about why things don't go wrong more often? And certainly in the practices we spent time with, we found that doctors were pretty safety conscious and cautious. You know, they knew who their patients were. They knew who needed to come in for face-to-face appointments, and they trained their junior staff well. And sometimes they did things that they didn't have to make patients safe. For example, get them in for appointments where necessary. You know, the rules say no face-to-face appointments without a phone call first, for example, but they would bring them in anyway. So lots of good things that we saw about why things aren't going wrong. So if we move to the next slide, what did we find when we looked more broadly at what the actual risks were? We had a long table in the study of places we looked, including NHS England complaints and NHS 111 logged safety concerns. And we found 95 examples over several years when, if you think about how many GP appointments happen every day, is not a huge number. So what sort of things came up? Well, from the doctor's side, it was things like not explaining stuff clearly enough to the patient, not recognising stuff that patients were saying about their symptoms over the telephone or how urgent it was, not calling a patient into the surgery when they keep calling after a diagnosis has been made on the phone. You know, they're not getting better. They also sometimes were not doing either enough checks on the patient or maybe sending them off for checks that they don't need, you know, not quite sure what checks are required because it's over the telephone, or occasionally giving them the wrong amount of medicine or too much or too little because they can't see them. And sometimes getting distracted by other things that were going on, like say a long wait. They knew there's a long wait for ambulances that day, that sort of thing. So those are some examples. And if we go to the next slide, other risks that we saw related to the GP surgery or practice itself from going through complaints were things like people not being able to get through because there's not enough phone lines or staff, something I think we all have experienced, or perhaps a complicated system for booking appointments online, such as an app that people can't use that meant that they gave up. The staff being distracted, it could be things like they were supposed to put a patient on an emergency callback list and didn't do it, or other problems about the practice itself, like there's limits on the number of face-to-face appointments they're allowed to give versus phone call appointments. And finally, things like practical things, like if you issue a prescription on a phone call and then it's not able to be sent to the chemist electronically. So it was things like that we found from looking at the wider examples. So moving to the next slide, given what we've learned there, I mean, there's obviously lots of things that doctors need to do, but is there anything that we patients can do to make it more likely that we get the right help and the help we need? Well, we took the results of the study to come up with some ideas. And I think, thinking very hard about how to try and make sure that there are things that we can do ourselves that might help. And the first thing, I think, it's pretty obvious, but, trying to think in advance, making a list, you might write it down, or just having a think about your main problems or symptoms before you get on the call. Some people are quite stressed when they're feeling ill, and it's thinking calmly before the call, trying to remember what things have happened. Sometimes you're not sure if they're symptoms or not, whether it's important or not. So having a think about that in advance. And we also found for some people, video calls or telephone calls for themselves are just an extra stress. Maybe your first language isn't English, or you've got hearing loss and a call can be more challenging. So in those situations, it really helps to have someone alongside to help with that. And then if we go to the next slide, and this one's about the appointment itself, our study showed very clearly that there are certain things that probably need a face-to-face appointment. And the list's there, but they include things like chest pain, feeling breathless, stomach pain, falls, lumps, urgent mental health, skin problems that won't go away, particularly a child or someone in care, and situations where you've already made a couple of phone calls and after 2 phone calls and things aren't getting better, you should probably go in. So those were things that we found in the study that were particular situations where in-person might be better. And then if you go to my final slide, I think the final things based on what we found that did go wrong, things that might be useful. Pretty obvious, but sometimes it's worth repeating yourself to make sure stuff doesn't get missed. You don't always get the same person, so if you tell a receptionist a symptom, it's making sure you tell the doctor as well. If you have other health problems, making sure that the doctor knows this, because it might change their advice on the telephone. And definitely if things are getting worse, make sure you tell the doctor that. And definitely get them to tell you what should happen next. What to do if you don't feel better, and maybe ask them to write it down and send it to you if that helps. So with all of that, I think I'll hand back to Trish, I think, to do the next slides. Yeah.
Absolutely. Thank you very much, Nadia. So this, as you can see, should be Dr. Emma Ladd's. I'm afraid she's a little bit under the weather this evening, so I'll present her 5 minutes as well as my own. Now, I was a GP myself for 25 years, and you get to know your patients, and we've got a lot of patients online. You know what it's like if it's a doctor that you know, or indeed a nurse practitioner that you know, things kind of go a bit more smoothly, mostly, because you each have an aspect of knowledge about the other. You have what we call relational knowledge. You know what kind of doctor that is. That doctor knows what kind of patient you are. So when you contact the surgery with your urinary tract infection, the doctor knows that, well, you're someone who gets particularly down when you get your UTIs, and maybe it would be a good idea if they just brought you in for a quick 5-minute chat, even though objectively perhaps you didn't need to be seen, you could have been dealt with over the phone. Now, relational knowledge is really important. Relational knowledge saves lives. There have been a number of studies which show that if you see a clinician that you've got a relationship with, you're less likely to get referred to emergency services, and actually overall you're less likely to die. So what did we find about relationship-based care in digitized and remote settings and transactions? And the answer is it can still happen, but it's much harder. And one of the reasons why it's harder is, even though you might still be registered with your doctor, the nature of remote and digital care is that it's often quite fragmented. And so, you know, if we take the urinary tract infection example, what you used to do is go and see the doctor, and the doctor would say, oh, sounds like you've got cystitis, pee in the pot and drop it in. And then that would probably happen straight away, and then you may or may not get an antibiotic. Now, it doesn't happen like that anymore. You might have a phone call, and then someone might ring you back, and then your little pot of urine gets dropped into the surgery, and then someone puts a dip in it, and then you might get a message on your phone. This is what's happening. It's being sent to the lab, etc. And so your consultation gets stretched out over time, over a few days, and a number of different people get involved in your urinary tract infection. Now, you may at some point speak to your own doctor, but you've also involved maybe half a dozen other people. And so it can feel very, very disjointed. Now, if you look on your electronic patient record, you'll find that it's all nicely, smoothly joined up. And so it doesn't necessarily look as disjointed as it feels. But what we have found in the RBD2 study is that for patients who need relationship-based care, and that is generally people with, for example, many different things wrong with them. Perhaps they're elderly, perhaps they've got some emotional needs as well as some physical needs, etc., etc. And let's face it, that's all of us at times. All of us need relationship-based care at some point. On the other hand, if all you need is some more of those tablets which worked last time for your shoulder, you might not care who gives them to you. So we're not saying that relationship-based care is needed all the time, but what we are saying is for those patients who do need it at the times they need it, it's much harder to achieve. And it seems to be going down the priority list as demand management seems to go up. And so one of the things I forgot to tell you at the beginning was how much higher that demand for appointments is now than before the pandemic. And that's for a number of different reasons. It's partly because of all the backlog of things that we held back during the pandemic. So please come in now, deal with whatever it is that you've been waiting to go to the doctor about. But it's also because booking an appointment for people who are quite techie has now become a bit easier, or sending a request to ask for an appointment if you're smartphone techie. And so what that means is demand is really high, and then a lot of the practices are on the back foot saying we must control demand, we must control demand, forget about having patients seen by their own doctor, let's just have any doctor will do. And so, yeah, it's not a great story, but we did have a few examples of how practices had managed to deliver good old-fashioned relationship-based care. And guess what? The patients were thrilled with this, and the staff were thrilled. And talking of staff, I think it's time to hand now over to Rebecca, who's going to tell us about workforce education and infrastructure, aren't you?
I am. So first I'm going to present some research by my colleagues, Dr Joseph Wharton and Professor Sarah Shaw, looking at technology and infrastructure. And they look closely at the different technologies and processes needed to do a remote consultation. And by that, I mean things like video platforms for the consultation itself, online platforms where people can go onto a web page to request and book appointments, and apps to send messages between surgeries and their patients. And this wasn't used routinely before the pandemic, but when the pandemic hit, they were rolled out rapidly with additional funding, and also some relaxation of regulation on what tech could be used when. So for our study, we looked at if and how practices continued to use and embed technology like these after the initial period of the pandemic. And here's a few of the key findings. The first thing is that there's no one-size-fits-all solution. Different practices needed different technology and platforms because they all work differently and they needed stuff that worked within their setting. And it's not just plug and play. You can't just buy an app and put it into your surgery. You need to fit the technology into the wider system. So Nadia mentioned the need for a prescription to go seamlessly off to a local pharmacy after a telephone consultation. Similarly, if messages are coming into the surgery, where do they go? Who deals with them? And the changes that sit behind the tech are really challenging in a busy clinical setting when there's stretched resources. Now, there were background problems with the existing infrastructure. I'm sure we're all aware of potholes on the road. Well, there's potholes in the internet connectivity, and the telephone systems didn't cope when everything suddenly went remote and large volumes of traffic were coming in. I'm sure many of us have had the experience of being on hold or getting engaged tones at the surgeries because the infrastructure just wasn't there to support the rapid deployment of remote technologies and is still catching up. Very often, local and national choices were made that affected what technology a practice could have. And sometimes when stuff was bought at a national level, it didn't fit the needs of the practice. So, for example, we saw that on the occasions where GPs did video consultations, they often started with a telephone call and then switched to a video consultation if they needed a bit more information. But one of the nationally bought systems didn't have the capacity right at the beginning for the doctor to text a link that the patient could click, because the way it had been set up didn't really align with how the GPs wanted to use it. So when we think about that going forward, it's really important that we help practices evolve and embed technology within their practices, because it's not about just buying new kit. It's thinking about what sits behind it and how the practice workflows can be adapted to link in with that technology. There's a real need for a focus on the basics. Internet connectivity needs to be there and telephony systems need to be fit for purpose. There's also consideration needed of how national and regional purchasing decisions can allow choice, because every practice is different, alongside the ability to adapt the systems for the local environment. And finally, developers of technology and services need to talk to patients and public to really understand and address the knock-on effects of introducing new technology. And we've heard about that from Gemma and from Francesca already, the unintended consequences of the rapid implementation of this tech. So that's the work from Jo and Sarah. I'm now going to move on to a work stream that I've been involved in alongside Trish, and that's education, training and workforce. And various colleagues have touched on already just how frazzled the workforce is. People have got calls and tasks coming at them from all directions, and the stress is particularly acute among the reception workforce. Very often, newer telephony systems mean that the receptionist can see how many patients are in the queue and how many are waiting, and that is really stressful. So you may have been waiting 20 minutes for a call, but that receptionist has been dealing with person after person, and it's really difficult to switch off from that as you move to the next call. We've also seen quite significant turnover among admin teams in particular. And again, that need to constantly train and develop people is stressful. But that stress and the adaptation to changing systems, changing government priorities, changing communications has been felt throughout the practice team. We also saw in relation to training and education that both established GPs and trainees felt they had additional training needs that had arisen due to this rapid implementation of technology. For the trainees, they felt they needed technical competencies. How do you use the kit? How do you make it work? And that can be really challenging with computer systems that keep crashing or platforms that are evolving. The skills to do an assessment of the patient by phone is different to doing it face to face, and they needed to learn general practice at the same time as learning how to consult in this different world. They had concerns about ethics and medical legal issues, and again about how to get that communication right over the phone and really pull out everything they needed from the patient to be able to understand what was going on and treat them effectively. But it wasn't just the trainees that felt this way. Experienced GPs were making ever more complex judgments, sometimes without the patient in front of them. Trisha's already touched on the increasing demands coming into general practice, and we see an increasing complexity as well in the things that are handled in general practice that in the past may have been handled at a hospital level. People needed to learn how to work within the limits of technology. And Nadia has mentioned some of those conditions that are less safe to be dealt with over the telephone. People needed to work this out for themselves, because at the start of the pandemic and really going on into later years, there hasn't been a massive amount of guidance about what you can and can't do remotely. We've had an increasing number of professionals come into primary care, and so the role has gone from being one of delivering care yourself as a GP to delivering care alongside supporting and supervising others. And that means extra knocks on the door as people come for advice or a prescription to be signed, and that need to really understand the needs of your staff and be able to supervise them effectively, alongside the need to support trainees. So that's it for the formal part of the presentation. I'm going to ask the panel if they could pop their cameras back on, and we'll pick up some of the questions in the chat. Please do put some more questions in, because it would be really good to have a bit more of a discussion. And I'm going to be putting the questions to the panel. And the first one is to you, Francesca. Could you just introduce yourself and your background and the role on the project?
Yeah, I saw that one. That's quite funny. Apologies. Yes, I'm Francesca Dakin. I'm a researcher on the Remote by Default 2 project at Oxford, where I'm an anthropologist by background, and I do social science research on that. I work on the workforce stream and the inequalities access stream. And then I'm also doing my PhD at the moment based in Oxford, broadly on similar topics, where I'm supervised by Trish in my final year. So these are all findings that are going into my thesis. Sorry for not introducing myself.
Great, thank you. So the next question is from David, who's asking, why aren't primary care centres or GP practices using live chat? Most businesses operate these systems and they're so easy to use. Anybody answer that?
Yeah, I can answer it. I think it's primarily because of safety issues. An awful lot of live chat is through bots. I don't know very many live chat facilities that are actually run by human. And I'm actually taking an AI course at the moment at the Saïd Business School, and there's a live chat help bot. And I ask it, please, can you connect me to a human because you can't answer my question, etc., etc. Now, my question is things like, where do I find the reading list for this course I'm doing? So it doesn't really matter if I don't find it. But if my question was, what do? I've got pain in my chest going into my jaw, and the live chat went back and forth and back and forth, then I might end up dead, and then one of my relatives might notice and take the practice to court, and all that kind of thing. So medicine's a safety critical industry. You don't have a live chat bot flying your plane either, that kind of thing. So that's one thing. But the other is that the amount of need and demand from patients at the moment is extremely high. The amount of resource and capacity in general practice is extremely low. And sure, it might be convenient to have a live chat with your GP, but there just ain't any GPs around. What have I missed, the rest of the team?
I suppose thinking about some of the people that we spoke to, they wanted to see or needed to see a doctor or a primary care professional and would just need to be navigated around that live chat. It wouldn't give them what they needed. So you could then end up having someone helping someone use the live chat, and it becomes a bit of a distraction. And it's certainly not very accessible for a number of people. And I think there is the other danger as well, is that people don't necessarily realise it is a chatbot. And that can be quite confusing for people if they're engaging with a chatbot and they think it's actually a person. That can be quite can feel quite deceived. They are being deceived almost, as well as quite confusing.
Although having said that, I want to come back and defend the chatbot here. Having kind of initially reacted against it, because I think David kind of got a point that interacting with a large language model chatbot might conceivably be better than filling out one of those ghastly forms where every time you answer a question up pops 10 more questions, and it's all very brittle and rigid, and it's sort of, do you or do you not have a rash? And you want to say, well, I sort of do a little bit of a rash and it's gone now, but it'll be back in 10 minutes. And there isn't an answer for that. And the thing about the large language model is that it can bring in context, it can adapt to what the patient is saying. And I think that just over the horizon, there may well be the pre-assessment chatbot, which does have a conversation with the patient, and the patient may actually respond in a positive way to that. I mean, I'm always amazed. I want to say thank you very much to ChatGPT, because it's sometimes so helpful and it really feels like it's trying to help me. So I think the idea that patients won't want it, but I do worry about the safety. And I think the thing is holding us back is whether or not this is going to be 100% safe. And I don't think we're there yet, but I think certainly within my lifetime it's going to come, and probably within the next 12 months.
Thanks. I see Lisa's put her camera on. Lisa, do you want to respond to this?
I do, if you don't mind. And obviously this didn't come out as part of the research, because it is emerging technology that we're seeing coming into the general practice. I am aware that there's chatbots that can sit in your telephone call flow. So if a patient chooses option 2, I wish to order a medicine, it can divert them off to a chatbot that can support them to use the NHS app. So it takes them out of the call queue, it takes the pressure out of the system, and it works at the patient's own pace. And of those products, we're seeing like 40% return back to them, where patients are happy to use them again in the future. And that's for predetermined tasks. So very much, I've got an action, I want to follow this pathway, I can do this. But I think we saw when online consultations were opened up, even though we may have given all kinds of advice and guidance on what they should and shouldn't be used for, it still happened at 3 o'clock on a Saturday morning after somebody had been out, they would submit an online consultation for something that was really seemed severe. And I think that's why general practice really do emphasize on the safety. There's certain channels just not the best route for submitting an online form and working with a chatbot. So I hope that helps just to set the context.
Thanks. I'm going to move on to another question now. Is your research going to help update any policy or make any improvement on the ground level? Trish, I'm going to ask this one to you.
Well, interestingly, you guys are not going to believe this, but one of the things we have to promise when we get funded by the National Institute for Health Research is that we won't make any direct recommendations for policy. We're not allowed to, as a condition of our funding. Now, why did they introduce this? Why were you giving all this public money to researchers and then say we can't change policy? And it's because academics are usually pretty rubbish at setting policy. What we're good at is doing the research, but we're often quite unrealistic about the constraints around policy. And of course, any academic who does a piece of research on X is going to say, you must do more policy on X, but I don't even know about Y, whereas the policymakers got to think about both X and Y and prioritise. Now, that doesn't mean that we haven't been working with policymakers. Of course we have. But what we have to do is do that through our relationships and through a kind of indirect influence, in that they can't take our findings and say this must become policy because Trish and her team of, they're clever people. They can't do that. What we can do is involve policymakers right before we do the research, before we put the bid in, and we have policymakers on our steering group. So, for example, Minal Bakai is on our steering group from NHS England, Margaret Warrissey from NHS Scotland. I'm getting the names wrong, but these are senior policy people, and they are on our steering group. They are hungry for the findings because we've invited them all the way along. And we were in the House of Commons a couple of weeks ago. We went off to London in our best clothes, and Baroness Finlay had a tea party, and there were 50 people there, some MPs, various people. So we're doing what we can to influence. So you now want to know what is going to change. I think one of the things that we've, done quite well with, we're now working with Health Education England around the competencies of different levels of staff. We've heard, as Rebecca was saying, the GP trainees saying they're not confident. They're not confident to diagnose people. They're not confident to handle things over the phone because they haven't had all that face-to-face apprenticeship. So one of the things we've done is we've put together a set of competencies. We're going to take them forward. We very much anticipate that they will be built into the training of different health professionals and support staff. That's just one example. Some of the things that we've found are a little bit tricky for policy because we've found, for example, that general practice could do with an injection of funding. And people say, well, that's not policy, that's politics. Yeah, sure. But we still said it, and we've said it in academic papers, and we've said it directly to the MPs and to the policymakers. So whether or not we're going to get more funding for primary care, I don't know. But some of the things we find have a relatively straightforward direction into policy. Another example is actually procurement. We've found, as Rebecca explained, practices struggling with something that was purchased a long way away from the front line, and then they're now stuck with it. Wouldn't it be nice if the system allowed the practices to buy what they wanted, etc., etc., etc. But that's an absolutely major policy change from the centralised procurement or relatively centralised procurement systems that we've got now. So some things are a bit harder. I think the other one that will go into a kind of policy is the findings that Nadia was presenting around safety. There are certain conditions that should not ever be dealt with over the phone, and there are a lot of other conditions that generally shouldn't be dealt with over the phone, and I think we are learning much more now than, say, 3 years ago when we began this study, that it's out there now. And I think the defence societies, for example, are taking that up, putting it on their website. One of the ones we put, Rebecca Rose and I wrote a very quick editorial a couple of years ago, and in it we had the phrase 3 strikes and you're in. And what that meant was if you've had the 3rd consultation over the telephone, if you're still not better, you come in and get seen. Those kind of things, I think they are now going into the business as usual of primary care, but not an easy thing to do. But thanks for asking the question.
Thanks. And we've had a couple of comments from the same person. So one is pointing out that even face-to-face people still get things wrong, but also saying he's very alarmed at the amount of missed appointments. This could cause patients not to be seen in time, could be fatal. Could remote appointments improve this? And I want to ask that to Gemma and to Francesca, because I think this is very relevant to your work. Does remote consultation improve access, or does it make it harder?
So, I mean, for the bit of research we've done around care navigation, we were looking at people who were finding it difficult. So for those people, it wasn't particularly helpful. But I have, in other related research for this study, found for some people remote appointments are really convenient. I interviewed somebody who was experiencing chronic pain and really needed to go to her appointments. Having a remote consultation was so much better for her. For the very reason that she was needing to go to the appointment, it made it hard for her to go there. So yes, for some people it can be really convenient, much better, and really helpful. But if you're struggling to get into the system, then I think that's the group of people we were looking at, and we found lots of reasons why that was problematic.
Yeah, and I would echo that, and also say that with that kind of increase in accessibility, as I mentioned, that does, of course, increase the workload for the people that are reviewing the patients. And so that becomes complicated in terms of like obscuring those patients that find it less easy to access care. And we saw in some of our practices, some ways of getting around this was ensuring that on patients' records, there were red flags. So, you know, reception staff who got requests from certain patients would know that actually this patient should be prioritized, or they definitely shouldn't be coming in and be given a remote consult. They should definitely be coming in. And I wonder if maybe there's a way to kind of, because that action kind of happens in response to patients trying to access care, maybe there's a way to build into the system kind of automatic flags that if we haven't heard from this person in X number of months, maybe send a check, like give them a telephone call or send them a checkup, just to make sure that they aren't being lost somewhere in the system. But yeah, Gemma kind of said it all.
Thanks. Now there's a question here from Denmark, from Ulrich, and he says, have you explored the time needed to treat, the estimated clinician time needed to prove the outcome for one person in the targeted population? Very relevant when developing new remote consultation guidelines.
No. Have you?
Maybe you could reply to that and let us know. Ulrich, something I want to say in response to that is actually we found a lot of the remote modalities have made care less efficient and meant that people have multiple contacts with lots of different people within the practice team about the same problem. And whereby in the past, we take the urine infection example, you may have just come in with your sample, seen one doctor, job done, out the door. Now there could be numerous text messages and contacts between different members of the team, and you may be involved with one receptionist, one HCA testing your urine, a couple of different clinicians, one on the triage screen, one sorting you out after you've had your urine dipped, and another one perhaps seeing you face to face if the other two couldn't get enough information. So we have found new inefficiencies being introduced into the system. Gemma.
Yes, and I just wanted to say something that in response to that also links with some of the other questions in around the care navigation role. And this was something we were concerned about. So you might have taken all Rebecca said around how some of those systems can introduce inefficiencies. Even if we do have a process that makes things more efficient for the general practice, that might push some work elsewhere for those people that find it difficult to access. So there's still some work that needs to be done. Who's taking that on? Who's got the time and the capacity to do that? So sometimes there might be an efficiency in one bit of the system, and you know, an improvement in terms of the amount of time it takes to do a task, but then someone else somewhere else is having to do that extra work. So that's the other thing that we need to bear in mind when we're introducing these things, that for the different perspectives in terms of who's actually going to benefit from those increased efficiencies.
Thanks. And we've got some comments in the chat from Deborah, who I think is a practice manager in North West Wales, about using Florey questionnaires for some UTIs, so it can save some coming in, but not all. Some still need to bring in a pot of pee, and giving patients the preference for face-to-face or phone, but the care navigator will judge suitability, and they can also send a link so people can send photos as well. Does anybody want to comment on that at all? Doesn't look like it. In that case,
I haven't finished thinking yet.
Sorry.
That was me being professorial and ponderously getting my finger in the air. I think one of the things that we've found in our data is that there is an enormous variation in what counts as a thing, if you know what I mean. So in the old days, before the pandemic, you'd have a 10-minute appointment and that would be your slot, and everything happened within that appointment. Whereas now there's all sorts of add-ons, pre-assessments and bookings and calling back. And actually one of the things we found in talking to the patients is they're not actually sure whether they've had a consultation at all. They actually think they've had a phone call, but that phone call, it might be very clear to me and to the receptionist that this is an administrative call. We're just trying to find out what's wrong with you so we can allocate you to the right person. But the patient may not understand that. They may not know that the purpose of that call is to put them in the right basket for the clinical thing. And I've personally talked to people in a different study, actually, and in a long COVID study, so I have not had a consultation, and you can look on the GP record and see that they've had 3, but the patient will say I've had 3 phone calls because they thought it was an administrative call. So what that means, coming back to Ulrich and the question of have you measured how much input is going into each of these things, one of the problems is that the thing that we're measuring is no longer a consultation, it's no longer a single episode of care, it's all just sort of splurged out a bit, which is why I'm getting a bit cynical about someone saying, well, each encounter takes 11.3 minutes or something like that. I think a lot of the work now is so mixed up that it's not really possible to measure it very accurately. Fran, you've probably got more data than I have on this.
Yeah, completely. The fragmentation point is a really good one. And I also wanted to, on the point of kind of variation and heterogeneity, kind of one of the main findings that we saw was that, yeah, there was a lot of variation in how each of these different technologies were being used. And that kind of had developed over time during the course of this study. And what that highlights to me is that actually there needs to be a lot more localized control over just how much remote technology is integrated within individual practice systems. And that's going to be best informed at the practice level by the staff that are there doing the work every day and who know their patients, who know what they need and what they prefer. And that is going to end up looking different in degrees that may be more or less severe across the country, you know, at the individual level. So more local control, I think, is what's needed.
Thanks. And we've got a couple of comments here about alongside the timescale of the study is the scheme whereby clinical roles apart from GPs have been funded by the Department of Health. This has impacted a lot on the fragmentation of primary care, seeing and dealing with multiple clinicians. And then another comment saying, are we underestimating the role of nurses in primary care in enabling patients to feel they've seen a health professional than some of those other roles? And I think that fragmentation of care is something that's really come across the whole street, all these different work streams we've been looking at, that fragmentation of care and its impact on relational continuity, on stress for the team, and on the whole system has been really problematic. Trish?
Yeah, just to pick up Jane's question, yes, sometimes patients really, really want to see the doctor, and actually they've got something that would be not only equally dealt with by a nurse practitioner, but actually dealt with better by a nurse practitioner, similarly paramedic, whatever it might be. And one of the things we have found is that if the patient knows that nurse, so many of the practices had, for example, an asthma nurse or something like that, and patients are very happy to go back to the nurse for that asthma because they'd already had an experience and they'd worked out that the nurse knew exactly what she was doing, etc., etc. But I think with the sheer number of different people that are around, and this is the point that Jean's making, patients can feel a little bit uneasy. And if it's the first time they've seen that health professional, they may well come out of their appointment or have their phone call with the nurse or whatever, the paramedic, and think, well, I better go and have another appointment with my doctor because my doctor knows me. But it's not really because the person they saw wasn't a doctor, it's because the person they saw was new. Or new to them. So I think we're circling back to Emma's work on continuity of care, and I do think that is really, really important.
Thank you. That's the end of the questions. Trish, do you have any concluding remarks before we hand back to Lisa?
Well, I thank you to everyone who's joined this. It's been great to have an opportunity to present our work. I think you've pushed us a bit on some of the questions you've asked, which is great. We're going back to the drawing board. One thing I should say is we had a little bit of money left over in our grant, not very much, not enough for us to go to the Caribbean or anything like that. But one thing we are going to do with that leftover money is continue to make some resources for patients. And we've, as you've seen, we've got some, but we're hoping to actually parcel up our findings a little bit more and make some infographics and downloads and that kind of thing. So watch this space, and hopefully we'll be sending them around.
Thanks. I'll pop a link to them in the question and answer section. And Lisa, over to you.
Lovely. Thank you, everybody. Really thank you for the presenters this evening. I hope that everybody on the call has enjoyed, found the information very interesting and useful. I think you've demonstrated as a team just how complex this has all become. Although we have got lots more technology available to us in general practice, this research has concluded that you just can't drop it in, that without careful planning or understanding of the impact on those different cohorts of patients, which could result in poorer access or outcomes for patients, I think it also can impact negatively on general practice teams, and you've evidenced that really well. There's been mention of the new roles, the additional roles that we now have in general practice, and the wider membership of the team who may have different skills and knowledge and could be better to see the patient, but actually that does impact on that relationship-based care. So I think people are being dealt with by a whole team now, not just one GP. And it may be that we need to think as patients, we might prefer to wait longer for an individual than access being always the most important thing. It's access to the right clinician. So I just want to say thank you all for contributing in the chat there. Once the recording's available, we'll let everybody know, and we hope that you share that with your networks, patient representative groups, and have a chat with your practices as well. I'm sure they'll be delighted to have engaged patients on their doorstep. So thank you, everyone. Okay, finished on
Thanks,
time
Lisa.
there.
Cheers, folks.
Thanks, everyone. Bye now.